Okay, I think we can go ahead and start now. Hi, everyone. Good morning. I'm Srinath. I'm one of the neurology chief residents. And thank you so much for joining us today for our grand rounds. We have an excellent speaker today who will be giving grand rounds, Dr. Marta Luciano from the University of California, San Francisco. And she will be talking to us about a very interesting topic, an update on dystonia. Dr. San Luciano is an associate professor of neurology at UCSF. She received her medical degree from the University of Navarra in Spain and completed an internship in internal medicine at Metropolitan Hospital Center in New York, and her residency in neurology at Boston University Medical Center, where she was also chief resident in her senior year. She then served as a clinical and research fellow in movement disorders at the Beth Israel Deaconess Medical Center in New York, which is now Mount Sinai, and then went on to earn a master's degree in clinical research methodology from the Albert Einstein College of Medicine. She was an attending neurologist here with us at SUNY Downstate from 2010 to 2012, before joining the Movement Disorders and Neuromodulation Center at UCSF. Her areas of clinical and research interest include the genetics of dystonia and Parkinson's disease, and outcomes research of surgical treatments for movement disorders. Thank you, Dr. San Luciano, for joining us. We look forward to this talk, and we are sure we're going to learn many new things today. So thank you again, and we can go ahead and start.
Thank you. Thank you very much for the introduction and for the invitation. Even though I'm still here in San Francisco, I feel like it's sort of homecoming, for me. SUNY Downstate has a special place in my heart as the first job that I ever had of fellowship, and I see some familiar names in the list of attendees. So I'm happy to sort of be back 10 years later. And also very happy to talk about one of my favorite topics, which is dystonia. Gonna get started. These are my disclosures. I received grant funding from the NIH and the Smart Family Foundation. I do have other non-financial conflicts of interest that I hope will not be part of this talk. Since it's so early over here, I think I'm safe. And I will discuss some off-label indications of medications and DBS devices. These are the goals for this talk: to have familiarity with the clinical features on phenomenology, to understand a new classification and genetic grouping, just to very briefly mention some of the most common genetic forms, recent ones, and basis for genetic testing, a little bit on the pathophysiology, and then having familiarity with medication, botulinum toxin injections. And I'll spend some time in neuromodulation because that's what I mainly do in the clinic. And this is the outline. So let's get started. This is the consensus definition proposed in 2013 by an international dystonia expert panel. Dystonia is defined as a movement disorder characterized by sustained and or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. It results from the imbalance of co-contraction of agonist and antagonist muscles. Dystonia is a type of hyperkinesia or dyskinesia and can be phenomenologically differentiated from other hyperkinesias, such as tremors or chorea. It is not a disease itself, but rather a symptom or a syndrome, and with many different causes. It has a very broad clinical spectrum. It varies in age of onset, distribution, severity, sites, and very importantly, it may coexist, with other movement disorders and other neurological features, which can provide clues to the actual etiology or ultimate cause. What makes dystonia is the stereotypic of or patterned or twisting posture assuming character. It predictably involves the same muscle groups in the same individual, as opposed to chorea, which is random. The fact that it's usually initiated or aggravated by voluntary movement, and that is associated with overflow muscle activation. That is the activation of muscles nearby that are not required for that particular movement. For example, to write, the involvement of the whole shoulder girdle. And lastly, sensory tricks or gest antagonists may be present, which are various voluntary actions that specifically correct the abnormal movement or posture. Typically, these simple movements involve the part of the body involved in the dystonic movement. For example, in cervical dystonia, touching the face, or the chin, may correct, the dystonic head movement. I'm going to show you an example right now. This is a patient with adult onset dystonia, cervical dystonia. She has a left tilt and retrocollis, and you'll see a very prominent head tremor. And then she will demonstrate, her sensory trick that calms her dystonic movement just by touching the chin. She's not forcefully moving her head. She's just gently touching her chin, and that will stop the dystonic movement. This is a list of several other conditions that result in abnormal movements, postures, and spasms, which are not associated with a specific phenomenology or dystonia. These are mimics or dystonia or pseudo-dystonia. In general, these conditions have a known or presumed cause that is different than the causes of broader dystonia groups. Dystonic tics or tics, that can look like dystonia, and orthopedic causes representing one of the most common ones. Differentiation also. So moving on to the epidemiology, it represents the third most common movement disorder after essential tremor and Parkinsonism that we see in the clinic. It compromises about 20% of visits at movement disorder clinics. It is very frequently under and misdiagnosed, so getting accurate estimates is difficult. But here are some estimates per 100,000 individuals for prevalence of different forms. Focal adult onset dystonia, specifically cervical dystonia or blepharospasm when the eyes are affected, are the most common forms by far. Just to give it a perspective, the global prevalence of Parkinson's disease is 300 per 100,000, but even the most common forms of dystonia will be about 30 per 100,000. There is a known relationship between the age of onset and the site of onset and the likelihood of spread of dystonia. So childhood onset dystonia typically starts in a limb, usually a leg or an arm, and can progress in a caudal rostral pattern. So leg to other leg or trunk, arm, neck, and face. Leg onset dystonia is more likely to spread to other body parts, more likely that cranial dystonia is spreading down. And with age, dystonia tends to be more localized, especially to the neck and the head area. So in people who start having dystonia in their 20s, 30s, 40s are more likely to have it just localized to the head and neck region. The current classification system in dystonia is a revision from a previous classification system, and it entails two distinct axes, clinical features and etiology. The combination of these two sets of descriptors is considered to provide meaningful information for clinical care, as well as to serve as basis for development of research and treatment algorithms. The clinical axis of features axis describe the phenomenology in a given patient, with 5 descriptors: age at onset, body distribution, temporal pattern, coexistence of other movement disorders, and coexistence of other neurological manifestations. This is useful for prognosis and identification of management strategies. And also, we have discussed previously the relationship between age of onset and distribution and the likelihood of spread. And specific etiologies of dystonia tend to have specific ages of onset as well, with different prognosis. In terms of location, we think about dystonia, whether it's focal, one body part, segmental, two contiguous body parts like neck and arm, multifocal, to non-contiguous regions, or generalized, when more body parts are affected. And the second axis addresses etiology, which is evolving as new information is obtained. And it focuses on 2 aspects. One is whether there are identifiable anatomical changes. And second, whether there is a pattern of inheritance that can be identified. Anatomical causes usually are investigated by brain imaging and very rarely by pathology. And inherited etiologies and acquired causes by means of metabolic, genetics, history, and other means. And these 2 characteristics are not mutually exclusive. And for example, a patient can have the characteristic eye of the tiger on MRI, as depicted in this picture, as well as confirmation of genetic testing consistent with autosomal recessive PCAN, or pantothenase kinase associated neurodegeneration. This brings me to talk about the causes of dystonia, briefly outlined here. Most cases of adult onset focal isolated dystonia will be idiopathic and sporadic. Maybe some people may have family history, and very rarely they will carry some of the identified genes. However, there are very distinct genetic causes, and I will mention a few. And then acquired dystonia, and we no longer use the term secondary. This is a little bit misleading. Encompasses those etiologies related to damage or alteration of basal ganglia and related pathways, like tardive dystonia resulting from the use of neuroleptic medications, dystonia secondary to stroke in the context of cerebral palsy from hypoxic ischemic injury. And it is important to remember that dystonia is a very frequent symptom accompanying neurodegenerative diseases, specifically Parkinson's disease and related, like corticobasal degeneration or multiple system atrophy. And specifically in young onset Parkinson's disease, dystonia, specifically foot dystonia, could be the heralding or first symptom. But what about the term primary dystonia that we've been using for a long time? This has been an etiological descriptor for both genetic and idiopathic cases in which dystonia is isolated and there are no associated pathological changes. But it can be confusing, so we don't typically recommend it. It's this dual meaning, clinical characteristics, and etiological implications doesn't bring clarity. Same as secondary, as I said. So let's move on to the classification of genetic etiologies of dystonia. This has been typically a very long laundry list of DYT plus number conditions, DYT 1, 2, 3, 4, up until the 20s. And this system was originally established to specify chromosomal regions linked to a familiar disorder in which the gene was unknown. However, this system has been problematic, and it went into a revision in 2015 from a task force from the Movement Disorder Society. And then based on this revision, for a gene to be associated that movement disorder prefix DYT, dystonia should be the most prominent feature of the disease, even though there may be other associated features. And then, if other movement disorders are present, like Parkinsonism, sometimes, you give it the prefix PARK, P-R-A-R-K, or others. And following a schema described by Dr. Tarsi in Boston, we can break up the dystonia genes that have been described into those that cause isolated and persistent, so just dystonia, and once it starts, it stays. Those that are combined, combined usually with myoclonus and Parkinsonism. Those that cause paroxysmal dystonia only at certain times, and person is normal in between episodes. And those, and a big bucket list of genetic etiologies that cause combined dystonia or complex. That means, there's dystonia is a part of a much bigger neurological syndrome, and that includes developmental delay, epilepsy, neuromuscular conditions, and others. And this list can be reduced to a smaller group of genes where the functional significance of the mutations is reasonably well accepted and has been replicated in several families. And even further reduced if we focus on those genes with multiple affected families, autosomal dominant disorders, which are going to be more common, and in the isolated and combined persistent dystonias. And I'm gonna mention very briefly a couple of the most common ones and show a couple of videos. And one thing to highlight is the emerging importance of KMT2B in early onset generalized dystonia, because this is a recently discovered gene and it is more common than one thought. It may represent up to 10% of childhood onset dystonia. It may present just as isolated, but it can also present as part of a more complex phenotype. And I'll show you one of our cases. Before I go there, just a brief mention on the role of genetic testing in dystonia and dystonic syndromes. So why pursue genetic testing in dystonia? It can be cumbersome and expensive. And I know, especially in New York State, it's even a little bit more difficult than in other places, but I hope I can convince you of its usefulness. It can confirm diagnosis, avoiding additional costly and invasive testing. It can relieve anxiety by giving the disease a name, even if the outcome or the treatment is the same. It can provide information of prognosis, and it provides appropriate counseling, including reproductive choices. Knowing the specific genetic type can guide treatment. For example, some specific genetic types have specific treatments, like levodopa for Dopa-responsive dystonia, or chelation for Wilson's disease, or antiepileptics, for PRRT variants that causes, paroxysmal kinesogenic dyskinesia. And also, it can affect, response to DBS. We know that certain genetic etiologies, like DIT-TOR1A, formerly known as DIT1, and epsilon sarcoglycan variants causing myoclonus dystonia, respond really, really well to DBS, but others do not. But it is important to know your phenotypes and syndromes to guide your specific testing, because this can be tricky. And also related to that, keep in mind that combined dystonia, so dystonia plus other neurological manifestation, has tremendous wide genetic heterogeneity. And having a good exam and identifying certain features can guide you in several different diseases to pursue testing for those. The ones in red are diagnosis not to miss, since they are treatable or have disease-modifying therapies, or are important not to miss. And this includes Wilson's disease, which can present very frequently with dystonia and tremor, and a range of movement disorders, vitamin E related syndromes, etc. And then many of these conditions would be detected in whole exome sequencing, but not all. For example, trinucleotide repeat disorders like the spinocerebellar ataxias are not typically included in single gene panels and will not be detected with whole exome sequencing. Classification along that first axis is aimed at facilitating clinical recognition. The clinical characteristics of dystonia and associated features describe defines a syndrome and can help in narrowing the etiology. And these are the most common dystonia syndromes encountered in the clinical practice, and some of the common genetic causes of those syndromes. However, this have a tremendous degree of overlap. So one type of dystonia syndrome presenting in usually in childhood is early onset generalized and isolated dystonia, and variants in TOR1A are the most common ones, followed by THAP1. That is the combination of myoclonus and dystonia and Parkinsonism, and then the most common cause, the most common presentation of dystonia in adulthood, which is adult onset focal or segmental isolated dystonia. And in some cases, there can be some genes associated with that. So for early onset generalized dystonia, this is a childhood or young adult onset. Mean age of onset is 13. It happens in all ethnicities, but due to a founder effect, it's more common among those of Ashkenazi Jewish descent. It is autosomal dominant, but with very decreased penetrance. So family history may not be that evident. Everybody has the same 3 base pair deletion, but there is a wide phenotypic spectrum. Onset usually in the arm or leg, may remain focal, but in most cases it will spread to become generalized. And it can respond to anticholinergics. It responds really well to surgical therapies. The pathophysiology is still pretty elusive, but it is one diagnosis not to miss, because again, you can respond quite well to surgical therapies in particular. This is one of our patients, he's 10 years old. He had onset of foot dystonia, foot inversion at age 6, that progressed pretty quickly to affect all limbs and trunk. Face and speech was spared. His trunk dystonia prevented ambulation and had to use a wheelchair. Focus on the very pattern. His neck always turns to the same direction. His feet always turn to the same direction. I will show you later on what happened to this patient. Dystonia related to THAP1 variants is described as mixed, because it is like the previous type, in which the onset is frequently early, a little bit later, mean onset age 16, and it tends to spread too, but like adult onset dystonia more frequently involves the neck. Onset in arm or neck is the most common ones, and affection of the legs is very rare, and very frequently people will have affected speech. There are multiple mutations in THAP1, and pathogenic variants are observed worldwide, even though there is a founder effect in the Amish Mennonite population, and something to think about it if you have a patient, with dystonia of that particular ethnicity. This 17-year-old had onset of neck dystonia, followed by arm and speech, with spread a little bit to the trunk. Okay. Notice the severity of her neck, but then the relative sparing of her gait. You can see a little bit of that left foot wanting to turn a little bit inwards, but ambulation is not affected in the majority of cases. I mentioned earlier KMT2B mutations representing a not an insignificant proportion of cases of childhood onset dystonia. Most have a variant de novo, although they can inherit it from their parents. More than 40 different mutations have been reported, and inheritance is autosomal dominant with very variable expression and reduced penetrance. Some are microdeletions, and the bigger the deletion, the more severe phenotype. Most of them develop generalized dystonia with very early onset, age 3, 4. That's very unusual for other types. It usually starts in the legs and then spreads. Palatal deep brain stimulation can be very helpful for this genetic type. And they have some additional characteristics, very subtle MRI findings, some dysmorphic features, some developmental delay in some cases. These pictures describe subtle dysmorphic features in these patients, from a recent Nature article. And this is one of our patients at age 5 with generalized dystonia and impaired isolation. I think over there in that video, she's trying to stand on one leg unsuccessfully, but you can see bilateral leg dystonia and hand dystonia. She does not have weakness. She does not have spasticity. She does not have hyperreflexia. She mainly has just dystonia, and she had a little bit of developmental delay. She went for surgery at age 5.5 and has done really well. Okay. Myoclonus dystonia, the majority of cases are due to variants in epsilon sarcoglycan. This condition has typically onset in the first decade of life, and myoclonus and dystonia coexist, although it does not need to be on the same body parts. And one characteristic of this condition, it has a dramatic response to alcohol, and patients need to be counseled because alcohol-related problems can happen. Psychiatric comorbidity is also very common: OCD, anxiety, and other psychiatric comorbidities. And there are other genes can be associated with this phenotype. The disease not to miss, when you see dystonia and Parkinsonism coexisting in the same patient, is Dopa-responsive dystonia. The great majority of cases are related to heterozygous pathogenic variants in GTP cyclohydrolase 1, which is in the pathway of converting tyrosine to dopamine. In these patients, there's going to be excellent and sustained response to levodopa without the appearance of the complications that we see in Parkinson's disease, without dyskinesias, without wearing off. Now, important is that differential diagnosis with young onset Parkinson's disease. So if the person is usually before the age of 20, it's more likely to be Dopa-responsive dystonia. If it's between 20 and 30, the likelihood is that it may be young onset Parkinson's disease related to Parkin mutations or others. And those patients will be at risk of, obviously, dyskinesias and other motor complications. And that is a neurodegenerative condition versus Dopa-responsive dystonia. Rapid onset dystonia Parkinsonism is a relatively uncommon disorder, but we still see it. And it is a very good example of genetic pleiotropy with different pathogenic variants along the same gene causing different syndromes at different ages. The classic rapid onset dystonia Parkinsonism is characterized by very acute, abrupt onset of dystonia in minutes or days, with very prominent cranial involvement and spread, usually in the opposite direction of TOR1A, so face down. It may have a waxing and waning course, but most of the time when the symptoms are present, they just stay there, and sometimes they can get worse. And it is a very unfortunate condition because it tends not to respond to medications or surgery. This is one of our patients. She was 11 when she first developed symptoms of hemidystonia suddenly while eating at a restaurant. and she has very prominent bulbar symptoms. You can see her grimacing right there, in addition to generalized dystonia. And she has had a stepwise progression of her symptoms, and unfortunately, she has not really responded to pharmacological or surgical therapies. You can see her truncal dystonia triggering as she voluntarily moves her arms and legs. Among the known and recurrent adult onset dystonia genes are GNL and ANO3. These are very rare, but they have been described, and just very briefly mention them. These are adult onset cervical dystonia patients that harbor these mutations. The phenomenology is that cervical dystonia, it can have a spread to the arm. This patient looks indistinguishable from a patient without mutations who have adult onset cervical dystonia. This variant has been reported in North America, Europe, and Asia, but is far less frequent than others. And it is inherited in autosomal dominant fashion. And then this is the other one that has been described primarily in the UK, anoctamin 3. This dystonia type was described again in 3 British families, and it has been replicated as a cause of cervical dystonia with a phenotype characterized. Oh, my video is taking a little long to load, with some cranial, laryngeal, and arm involvement, but no significant leg dystonia. One thing I would say about all these dystonia genes is that we, even though we have the gene identified and what the protein does, the connection between that protein function and the development of dystonia remains elusive. So after this information, how do we go forward with genetic testing? What are the options? So candidate gene testing, especially when the disease is known in the family, whole exome sequencing or whole genome sequencing. So we first think about the phenotype and associated signs to guide testing. So if ataxia is present or if MRI findings are suggestive of NBIA, you may want to opt for an ataxia panel that includes the trinucleotide repeats, or an NBIA panel. But for isolated and combined dystonias, just dystonia or dystonia a little bit of Parkinsonism, dystonia and myoclonus, panels are reasonably inclusive, although some may not have one of the newer genes. And panels, especially panels by Invitae, are of no cost, at least with Medi-Cal, which is the California equivalent of Medicaid. I know New York is a little bit different with terms of genetic testing. Whole exome, whole genome is the most comprehensive, but it's the most difficult to analyze. And whole exome has the advantage of picking up a wider range of disorders, but also incidental findings are picked up, and variants of unknown significance are pretty common. And patients should be counseled about that. And I will just briefly say, that in general, our yield is between 15 and 25% to identify genetic cause in people that we suspect a genetic cause of dystonia. And that's not that dissimilar to other conditions like muscle dystrophy. I will briefly mention that the presumed pathophysiology of dystonia is thought to involve loss of surround inhibition at multiple levels in the central nervous system, dysfunctional plasticity, and abnormal sensory-motor integration. We know that at the structural level, anatomical lesions in the basal ganglia, but also cerebellum and motor cortex can cause dystonia. FDG PET demonstrates a very distinct activation pattern in basal ganglia and cerebellum, even in non-manifesting carriers of some of those genetic forms. And we know from DBS studies, from neuronal recordings, from depth electrodes, that we can identify, very characteristic low frequency oscillations, different than the ones that we see in Parkinson's disease, in pallidum, subthalamic nucleus, and in cerebellum. And this imbalance in striatal circuitry can result in inability to focus on isolated muscle groups that can result in these agonist and antagonist co-contractions and long bursts of muscle activity leading to overflow and co-contraction and tremors. Very briefly, I'll go a little fast on the treatment. With very few exceptions, there is no pathogenesis guided treatment for dystonia. because we lack evidence from controlled trials and the choice is often empirical. But it's important to remember that the goal of therapy in most cases is symptomatic relief, not only of the movement, but and related pain in some cases and discomfort, but also the associated features and comorbidities, including mood disorders and orthopedic complications. These are overarching principles adapted for a classic article by Joe Jankovic from Texas. Perhaps the most important consideration is the understanding that it is heterogeneous and not a single disorder. And the first principle is to, if possible, identify the treatable cause and act accordingly. But beyond that, education, addressing the comorbidities, emphasize that the treatment is symptomatic, and then very individualized therapy, combination of different types of therapy, including physical therapy, and then evaluation for surgery for severe cases is sort of the overarching plan, for many of these patients. These graphs are from a review that I highly recommend, from Dr. Belind in the UK, with very practical advice that, for example, combined dystonia that has myoclonus, use antiepileptic drugs that will have anti-myoclonic activity. For dystonia and Parkinsonism, obviously we're going to use dopaminergic drugs. And for those associated with spasticity, in the context of cerebral palsy, for example, we will use medications that help spasticity, like baclofen or dantrolene or benzos. But in general, focal dystonia is treated first with botulinum toxin injections and adjuvant physical therapy. I did draw a red line into some medications because some patients might benefit, from medications at night, like benzos. And in generalized dystonia, the first line is going to be medications, although in some cases it might make sense to do also injections. There are some disorders that have specific targeted therapy, and very briefly, I will mention those. Most of these have complex dystonia associated with other neurological manifestations, but treatment early may prevent, reverse, or mitigate symptoms. And this is from a review from Bazgina from 2018, and he uses a group of mechanisms that includes reduction of toxic products, like in Wilson's disease, dietary interventions, like abetalipoproteinemia, vitamin supplements, homocystinuria, some trigger avoidance. I mentioned rapid onset dystonia, Parkinsonism. In some cases, that disease can be triggered, by alcohol. So avoidance of triggers, can be helpful, or specific drugs. And the biggest example is Dopa-responsive dystonia and levodopa. I do want to mention briefly drug-induced dystonia and by association, drug-induced dyskinesia. This is a hyperkinetic movement disorder that is iatrogenic, follows the exposure to dopamine receptor blocking drugs. And this condition remains a problem because of expanded use of second and third generation antipsychotics, despite their lower risk. So these are the general guidance of treatment. Most importantly and frequently overlooked is prevention by prudent use of these drugs. Then early diagnosis, which will affect prognosis if treatment is initiated early. Second, and usually equally important, is discontinuation, very slow discontinuation of the offending drug if possible. This is in conjunction with psychiatry, if this was for psychiatric indication. And then I try always to convince our partners in psychiatry to not use anticholinergic drugs, which can worsen tardive dyskinesia, will not prevent drug-induced Parkinsonism, and it can be associated with significant side effects. And then only if needed at that point, specifically, use antidystonic and dyskinetic medications. And I do spend some time on this because there are new medications that have been FDA approved, for tardive dyskinesia, and you may have seen them. Those are deutetrabenazine and valbenazine, Austedo and Ingrezza, and they have gone aggressive in marketing. These are FDA approved. These are dopamine depleters or VMAT2 inhibitors. They have advantages over tetrabenazine, which was the first one, to be approved, although not for this indication. But even though they have an improved side effect profile, they can cause Parkinsonism, they can cause severe depression and suicidality. So they have to be used with caution. And I mentioned this because deutetrabenazine is now advertised on TV. I saw this ad, I think on Super Bowl Sunday, following an ad for Abilify, very apropos. And this ad portrays a supermarket worker with mental health problems who reported unintended body movements of the face and arms. And her doctor told her that Austedo could reduce these movements while people continued on their mental health medications. But again, I would like to remind you that the first step in treating tardive dystonia, tardive dyskinesia, is to try to discontinue the offending drug, which in many cases can result, or switch medications, in improvement of the movement disorder. I'm going to very briefly breeze through medications used for dystonia. Okay, I'm having trouble with my mouse here. Oral medications mainly considered for generalized forms or adjuvant therapy, for focal forms. They tend to be better tolerated in younger individuals. And on their own, they have modest benefit, with very rare exceptions. And we use medications that are dopaminergic, rarely anti-dopaminergic, anticholinergic, baclofen, benzos, and others. In terms of dopaminergic therapy, carbidopa, levodopa, obviously the drug of choice for Dopa-responsive dystonia, but other types of dystonia may respond, not to the same degree, but we also always try it because it's cheap, it's available, and it's well tolerated. And in some cases, it can provide benefit. Anti-dopaminergic therapy had extensive use in the past. We don't typically use it, with two exceptions. One is Clozaril for tardive dystonia, if we need to, and the dopamine depleters that I just mentioned for tardive syndromes when needed. But anticholinergic therapy is the anti-dystonic drug, by drug type, by excellence. It is helpful in most types, but it is poorly tolerated in adults. That is trihexyphenidyl, artane, but also benztropine and others. There is a Canadian one called Parsitan or erythropropazine that has less CNS side effects. The peripheral side effects, dry mouth, constipation, can be overcome by using, for example, pyridostigmine or other things, but the central side effects of like mental fogginess can only be addressed by reducing the dose or eliminating the drug. Okay. Baclofen is likely the most effective antidystonic agent and particularly helpful when dystonia is associated with spasticity, and that is common in cerebral palsy or after lesions. It can be used intrathecally, usually in spastic dystonia, dystonic cerebral palsy, with many trials backing its use. However, it's not devoid of potential side effects and surgical complications. Benzos are commonly add-on medications. They provide additional help, but sedation is a frequently dose-limiting factor, so we tend to use that mainly at night. And muscle relaxants. I will mention briefly a couple of drugs in trials. Sodium oxybate, or Xyrem, frequently used for narcolepsy, is currently on trials to address movement disorders that respond to alcohol, like in myoclonus dystonia, but also specifically spasmodic dysphonia, voice tremor. With some preliminary good effect in efficacy. And then there have been some positive reports from using zolpidem in focal dystonia forms. Very briefly, I mentioned, because we can talk about botulinum toxin injections, for hours, that the introduction of Botox into clinical practice revolutionized the treatment of dystonia. It exerts its mechanism by denervating temporarily and partially the injected muscle. It is safe and efficacious, but that depends on the appropriate dose, the muscle selection, identification of the target muscles, and not compensatory antagonists, and having realistic expectations, among other factors. There are 4 FDA-approved botulinum toxins that are used. It's important to remember that the units are not interchangeable. And even though they're all FDA approved for adults with cervical dystonia, not all of them are approved for other indications, even though and most clinical uses are off-label, even though the toxin is considered the first-line therapy in focal dystonia, such as blepharospasm or mandibular dystonia, arm dystonia. skip that. The effect starts about 1 to 2 weeks, picks up 4 to 6 weeks, and wears off by 3 months. Even though it's remarkably safe, it carries a black box warning related to weakness. Especially careful, have to be injected in the anterior part of the neck to avoid dysphagia. I'm going to move briefly to surgical therapies. There are 4 options: intrathecal baclofen, briefly mentioned already, peripheral denervations, which used to be extensively in the past, although we don't use them anymore because of side effect profile, including weakness and dysphagia. It was used to treat mainly adult onset cervical dystonia, and they have high rates of recurrence. And then the brain surgeries, ablations or deep brain stimulation. Both pallidotomy and thalamotomy were the first surgeries to be highly effective against dystonia. Oops, excuse me. And still represent an option for a subset of carefully selected patients. And that brings me to the new therapy called focused ultrasound, or MRI guided high frequency focused ultrasound. This is a new technique for ablations, mostly studied and FDA approved for essential tremor, and tremor in the context of Parkinson's disease, and more recently pallidotomy for Parkinson's disease. It avoids the need of a craniotomy, but like ablations are pretty much only safe for unilateral use, because we know the studies, from the 50s, 60s, and 70s, bilateral thalamotomies carry a high risk of permanent speech disorders and other potential complications. This technique is marketed as non-invasive, but I always argue that you may not have a hole in your skull, but if you end up with a hole in your brain, I think that's pretty invasive in my book. But there's been, it is highly effective, for the management of dystonic tremors, and as well as musician dystonia, again, only on one side. And then DBS is approved under an humanitarian device exemption since 2003. It has class 1 evidence for effectiveness in generalized and cervical dystonia. And on average, for generalized isolated dystonia, has an improvement of approximately 70% in motor rating scales. It's noteworthy that there are different types and etiologies that respond differently. For example, isolated generalized dystonia responds the best, and people do best the younger at surgery, shorter disease duration, higher baseline severity, and acquired and complex, especially with demonstrated basal ganglia damage, they tend to do worse. One exception of acquired forms is tardive dystonia. Tardive dystonia that is severe enough to warrant surgical treatment tends to do very well. So let me show you the patient from before. This is at age 10. And this is him about 6 months after deep brain stimulation surgery. He's now in college, and we see him every 6 months or so, and has continued benefit. You can still see a little bit of dystonia in his right foot, and then occasionally his neck. It is not perfect, but it is really good. Adults with cervical dystonia also benefit, and there's class 1 evidence. And I'll show you one of our patients, with predominantly anterocolis, which is very difficult to inject because you have to inject the anterior muscles of the neck that carries a high risk of dysphagia with botulinum toxin injections. And that is him about 6 months after surgery. Deep brain stimulation tends not to improve voice dystonia. I mentioned earlier that acquired dystonia typically does not improve as well. This is one of our patients, with cerebral palsy. And this is 6 months after surgery, with improvement in his neck, but still, with a lot of residual symptoms. This is one area of focus that we have in our center in trying to discover new targets, for dystonia, for DBS and dystonia, for those, with basal ganglia damage. Tardive dystonia responds really well. Not everybody responds to the same degree, and there are some predictors of who can do better or worse. I'm going to move pretty quickly because I know I'm out of time. So pallidal target has some limitations, some non-responder rate, slow response to stimulation. It takes weeks to months. and some potential side effects. So we're exploring different targets, including the cerebellum. And people who are the youngest, who have normal MRIs, short disease duration, do best. Where are we going with this? We're expanding indications and brain targets. We're identifying, brain signals that can guide adaptive stimulation and improving targeting. And then just briefly mention physical therapy is tremendously helpful in helping, with the discomfort and pain and postures. And there are other therapies, although they've been less well studied and tend to have transient benefits. And then I want to give a special thanks, to my team at UCSF, and as well as my friends and mentors on that coast, Rachel Sanders-Blumen and Susan Bresman, now at Sinai, whom I first learned about dystonia. And thank you very much.
Thank you, Dr. San Luciano. That was a wonderful lecture. It was very interesting. Now we have time for questions.
Okay. See, Susan Law has a question.
Hello, Dr. San Luciano. It is so nice to see you again, and thank you for this lecture. Every once in a while, we have a stroke patient who has a dystonic reaction. Are there any tricks and tips on differentiating that between spasticity? And the second question is, what treatment options can we use as clinicians to take care of that stroke-related dystonia?
Yeah, that's a very good question, and a common cause of dystonia. I would say that when dystonia develops after a vascular event, it doesn't develop right away. I know spasticity doesn't either, but dystonia tends to appear later. So spasticity takes it first, and then dystonia is at least about 6 months later when it starts. In dystonia, one tone should be normal, but the problem is after lesions, it is very common to coexist spasticity and dystonia. In fact, that is a topic, that we frequently talk about, how much is spasticity, how much is dystonia. In general, posturing is going to be more dystonic, than just pure increased tone. But again, they're going to coexist. So in terms of therapeutics, therapies that are going to work for both. I mean, if it is very focal in terms of, an arm or leg, botulinum toxins are going to be the sort of number one therapy if they're predictable muscles that can be injected. Now, in the upper extremity, if there is residual function, if they can use the hand, got to be very careful with residual weakness. And then, very severe cases, then go medications. Baclofen is going to be my top one. Baclofen, dantrolene, benzos. If it is very severe, both spasticity and dystonia, intrathecal baclofen is a possibility. But I would say injections then followed by the drugs that can address both, because very frequently they're going to coexist.
Thank you.
I have a question.
Yes.
For your patients with severe tics, Tourette's, what is your experience with DBS? Because occasionally I have a patient who is medication resistant or refractory.
Yes. Oh, you're bringing the tough questions. We have implanted in people with severe Tourette's, not many. It can be helpful, I would say, from the patients that we have implanted, and we've implanted maybe like 5 over the last like 7 years or so, as compared to about 200 a year for Parkinson's disease and so forth. It is, and our response to that has been like a bit 50-50. Some people have done very well, some people have not worked at all. So one thing that I have learned over this process, and I tend to follow those patients, is that if there is any hint that the Tourette syndrome is secondary or part of a bigger umbrella, like for example, autistic spectrum disorders, DBS will not work. It just will not work. People who have had tick-free periods in their life, tend to be a bit more akin to, to be able to modulate with DBS. But we don't know what the right target is. The studies are all over the place. So globus pallidus, thalamus, accumbens. So it is a therapy that it is evolving. We reserve it obviously for very severe cases, especially if there is self-harm in the ticks. But then you worry also to put them through surgery and have incisions, where they can pick at them. And we've had that issue happen before. So not very satisfactory, I have to say, DBS for ticks at this point. But in some cases, this is the only thing you have left. Yep.
Thank you so much.
Back in the day, we used to use a lot of botulinum toxin, particularly for torticollis. That's no longer used, I think.
Oh, we do use it. It's the first line treatment for torticollis or adult onset cervical dystonia. That's the more appropriate name. And that is the first line of treatment. Okay, we wanted to know if there's specific network involved in dystonia. Yeah, the Dystonia Medical Research Foundation, the DMRF, it is a sort of network, for dystonia centers that provide not only research grants but also potential for collaborations. I would say that's the main one. And then the Movement Disorder Society as a networking tool.
Hi, Dr. Luciano. Thank you for the lecture. I wanted to ask for the DBS. Did you prefer only for primary dystonia, or did you? Because I read some studies that it's mostly only effective for primary dystonia, or did you try other secondary cause of dystonia with DBS, or did you see any benefit in that?
So it is true that deep brain stimulation tends to have better outcomes. So pallidal and subthalamic DBS, has better outcomes in isolated dystonia, specifically certain genetic types. They tend to do very well. That the patient I showed. Now that is not the most common type of dystonia. In fact, the most common type is acquired, and I see a lot of kids and young adults, specifically with dystonic cerebral palsy, in which the dystonia it's secondary to basal ganglia damage, usually, from perinatal injury. And we do implant those patients. The response is not as robust, but it can be associated with significant improvements in quality of life. We are currently exploring cerebellar stimulation, so putting the electrodes, through dentate nuclei and terminating in superior cerebellar peduncle. For those cases in which we know the basal ganglia and parts of the thalamus are more damaged, but mainly the basal ganglia, mainly pallidum and striatum, and with the idea that we will modulate more the cerebellar thalamic pathways involved in dystonia as a potential better target. Because again, yeah, these cases do not do as well, but still can do well enough. For example, we look for gains like ability to be able to manage their own wheelchair, like to stop the overflow so that their movements are a little more precise, so they can use their own wheelchair, or that they no longer harm themselves because they have so many involuntary movements that they're hitting their face or hitting caregivers. So the expectations are different, but we still do it. I'm sorry, there was a clarification there. Mechanistic network or anatomic. Okay, I'm not sure if I understand the question. Oh, the network. Oh, you mean the network? Okay, sorry about that. The brain network. Yes. So yes. So basal ganglia circuitry is the one that is primarily understood to be involved in dystonia. However, more recently, cerebellar thalamic, cerebellar rubrothalamic cortical pathways are known to be involved as well, and the communication between the two. That is the specific network that is thought to be involved in dystonia. However, not nearly as developed as in Parkinson's disease, I would say.
When you see an adult patient in your clinic for an episode of the first episode of dystonia, how do you know it's genetic or it's just an isolated episode? And at what point when they have recurrent dystonias do you decide to send the genetic panel?
Well, you're sort of assuming there that there's an episode, so that it happened and it got better. That points to a very particular type of etiologies. In general, isolated dystonia related to some of the genetic variants are isolated and persistent. Dystonia appears and dystonia stays. So that points to very particular etiologies. In general, if you have the earlier the onset, the more likely you're going to think of genetic etiologies. In adults, I did present a couple of genes there. That's fairly rare, more likely going to be sporadic. Now, the paroxysmal dystonia, that's dystonia that happens in episodes, have very particular genetic basis in some cases. And there are panels that will pick up some of those genes. My approach is obviously getting a very good history. If there's any family history, absence of family history doesn't rule out a genetic condition, because many of these genes have decreased penetrance, and it may not be obvious, or the symptoms will be so subtle in family members that may be missed. But if there's just dystonia, sort of isolated dystonia with nothing else, and no identified etiology, they were not exposed to neuroleptic drugs, the MRI is normal, or the MRI may point to a particular genetic etiology, but if those are the type of patients that you may suspect a genetic etiology, and we will send a genetic panel as the first pass. If there are obviously other signs or symptoms, any subtle thing that may point to a different, then we'll target those testing. But I would say the most common type of dystonia that's going to walk into the clinic, which is going to be adult onset, isolated cervical or cranial dystonia. Even though we may suspect, some genetic predisposition, I don't think, we know, all the genes and the panels, most likely will be negative.
Thank you.
Great.
Yeah, I think we have no more questions. So I want to thank you again for this very interesting talk and for joining us today. And thank you everyone for your time.
Thank you. Thank you very much. It's wonderful to see familiar faces 10 years later. Don't wait 10 more years to invite me over again, please. Bye-bye.
Thank you. Take care. Have a good weekend, everyone.
Thank you.